Hello, my dear friend. A very warm welcome to all of you in this recall session of FMG July. And when I was at the exam center, a lot of students told me that, sir, the questions looked simple, but it was not simple at all. Many questions were from the deep topic. And now we cannot finish our preparation just by revising PYQ. We need to have a complete grip over the topics of PYQ. So that's why in this session, my main motive is to give you complete grip of the topic. Okay. Plus, of course, I will try to give you a better and very good recall, but I can also do some mistakes. So please do correct me if my recall is a bit wrong or anything. Suggest me the correct changes in the chat box. So let's start the session with this one of the most confusing question, that the delivery in type A PHC. We all read that less than 20 type A, more than 20 type B. But what is if the option they say less than 20? Because one of the student, he messaged me also that one message was less than 20, one message was equal to 20, and one message was equal to 30 or less than 30 or more than 30 was the options. So for that thing, it is clearly written in PAAR, if you will see, that PHC may be of two type. Type A is less than 20 only, and type B is the one with 20 or more delivery. Okay. So type A less than 20, type B 20 or more. This is one clear message. Plus in this page you can see all the work done by PHC, which we can remember by the mnemonic elements of PHC, which they ask, and you all must know about the 4 pillars of PHC. Okay, which they ask again and again from this topic, out of which one main pillar is adequate technology, which they confuse. Okay, adequate technology, equitable distribution. And they sometimes ask this question in this way, that which pillar is not, which of the following is not a pillar of, out of the 4 pillars, which is not a pillar of PHC. Option A, they will give adequate technology. Option B, they will give equitable distribution. Okay. Option C, they will ask as intersectoral coordination. And option D, they will give community participation or universal health coverage. So which is not a pillar, they can ask. Okay. Always focus on this question also while revising. And I hope you all know that universal health coverage is not a pillar of PHC for sure. And PHC can be type A, type B. Similarly, subcenter can be type A, type B. If the subcenter is type A, then there is no delivery in there. If the subcenter is type B, then we can have delivery there. So type B is the advanced version of both subcenter and PHC. Plus similarly, they can ask for CHC also. CHC type A will have less than 100 delivery. Type B will have more than or equal to 100 delivery. So remember, less than 20 is type A. But if it is equal to 20, it becomes type B. So answer is only A. Less than 20 is type A PHC. Okay. Equal to 20, type B. One more question was, which is being done wrong in many time in recalls also, that which of the following is direct cause of maternal death? And some students said that it was not direct, it was indirect cause. So we have to know what are the direct and indirect causes of maternal death. And it is clearly written again in PAAR, so you can focus here and you can read that. Indirect cause include anemia, malaria, heart disease. These 3 are the main indirect cause. Anemia, malaria, heart disease, out of which, of course, anemia is the most common indirect cause. What are the direct cause? Direct cause, most common direct cause is postpartum hemorrhage, which is directly leading to bleeding. Now, why anemia is indirect? Because anemia first reduces hemoglobin, and then because of less iron, less hemoglobin, poor absorption occur, platelet count is also less, so bleeding is more, and then postpartum hemorrhage happen and female die. So PPH is not directly happening due to anemia, but indirectly anemia is contributing to it. So PPH is one direct cause. Then the second direct cause is obstructed labor, very common. Third direct cause for Indian continent can be the sepsis part, infection part, directly causing the death and all. So in PPH, again they can ask what is the most common cause. So PPH is most common cause, and PPH can be due to two reasons. One reason is atonic uterus. Uterus is not contracting. And second reason is retained product of conception. That means some placenta part is being left in the uterus and all. Retained product of conception. So remember, atonic uterus is the most common cause causing postpartum hemorrhage. And what are the indirect causes? Three indirect causes are there: anemia, malaria, heart disease, which they have written. What are the direct causes? Ectopic pregnancy, embolism, anesthesia related death, PPH, obstructed labor, sepsis. These all are direct causes. Okay. So let's see what are the causes, and I have given you this full detail of the topic so that you can go through it. In India, remember, PPH is most common cause of maternal death, and premature delivery is the most common cause of infant death in India. So which is a direct cause if they ask? Embolism can be a direct cause, but heart disease, anemia, diabetes and malaria, all of these are indirect cause. Okay, embolism is a direct cause. Now, if the question was this, which of the following is an indirect cause, then in indirect cause, of course, anemia will be a better answer than heart disease. Because sometimes heart disease can not only just present as hypertension in pregnancy, but can cause eclampsia and death also. So the better answer will be anemia in this case. Okay. Because anyway, anemia is the most common indirect cause of death, and PPH is the most common direct cause of death. I hope you will remember this classification of indirect and direct. Okay. And you will be able to do it correctly. This 6x6 strategy under Anemia Mukt Bharat include all except they have asked. So, in this Anemia Mukt Bharat, the first 6 are the one who will get the benefit. Second 6 are the things which we will do to decrease the death. And last 6 is the mechanism by which we will give it. तो कुल मिला के बड़ा ही छक्का प्रोग्राम है ये, 6x6x6, and in this coordination and ministry is not directly one of the 6. The 3 6 are beneficiary, intervention, institutional mechanism. So last year also they have asked that in Anemia Mukt Bharat, what is our target? Target is to reduce anemia each year by 3%. And what are the 6 benefits which we give under this program? So the first benefit is, of course, iron folic acid tablet. Second is we give twice a year albendazole. So it is biannual albendazole. Third benefit is BCC. BCC means behavior change communication. So we say this word: solid body, smart mind. Okay. Before giving iron tablet to children, we will say if you eat this, you will be able to hit all the children of the street. You will be solid body. So the child might eat it. Before giving it to the pregnant mother, we will say that if you will eat it, your child will come first in the class. And he will be a smart mind. So the mother might eat it. So solid body and smart mind, this can change the behavior and the patient can take the tablet. So this is behavior change communication. And this is also the logo of Anemia Mukt Bharat program. The fourth is that we have to focus on fortification of food with iron. जैसे salt में iodine होता है, similarly we are trying to fortify other food or salt with iron and folic acid. The fifth is to do digital HB measurement by HemoQ machine, just one drop and do the measurement. And along with that, also do the follow up of high risk anemia cases which have severe anemia and all, follow up for them. The last sixth benefit is that we have to focus on other cause of anemia also. One cause is nutritional anemia, which is iron deficiency anemia. Other causes can be malaria, thalassemia and all. So focus on other cause. This is the other cause like malaria and all. This is the sixth benefit. So are you able to remember the six? IFA, albendazole, BCC, food fortification, focus on other cause also, and distal HB measurement. 6. Now what are the 6 mechanism they ask? So this is 6 into 6 strategy. This 6 people get benefit and 3% is the target for reduction of anemia. These 6 are the intervention which I just discussed. The mechanism is something which is almost similar. They say first we will have National Anemia Mukt Bharat unit, and here they are trying for unit, and then here they are saying that we should have an excellence center for anemia. So unit will be excellence center only now, but they created 2 mechanism out of it. Then they are saying interministerial coordination and convergence with ministry. So coordination is same as convergence now, but one work is created into 2 things. So these are the institutional mechanism by which they will work. Then after this 4, one is higher center, other is nutritional anemia center. One is coordination, other is convergence. Then the remaining 2 are strengthening the supply chain and logistic and creating Anemia Mukt Bharat dashboard, digital portal, one stop shop for anemia. So these are the 6 institutional mechanism. Okay. Now, one student suggested that, sir, they have asked a different type of question here, that which is not included under Anemia Mukt Bharat program. So for answering this type of question, you have to know what are the benefit. First benefit, I said iron tablet and folic acid of course will be given. Albendazole is given. Antibiotics is not given. Now, many a time they ask the dose of IFA tablet that we give. And the dose can be easily remembered by the mnemonic PBR, just as we go to watch movie in PVR. The mnemonic is PBR. And of course, some people go to PVR to do other work also. So in PVR, movie is released once a week or twice a week. Of course, it is released once a week, every Thursday and all. So these 3 group get tablet once a week. Pink tablet is for 5 to 10-year children, and they get 45 milligram iron and 400 microgram folic acid. Then B for blue, blue tablet is for adolescent, okay, 10 to 19 year, and this has been asked in INICT also. They get 60 milligram iron and 500 microgram folic acid. 60-500. This R is for red, and this red is for adult female between 19 year to 46 year, and they also get the same tablet, 60 and 500. 60 milligram iron, 500 microgram folic acid. So these are the 3 beneficiary, pink, blue, red, all are once a week. Then of course we also give the tablet in pregnant and lactating female, and in them we don't give tablet once a week, of course. And we will give them tablet once a day. If we will give once a week, they will throw it at our face. So we will give it once a day for 180 day before delivery, that means from 4th month of pregnancy to 9th month, and 180 day after delivery. So it is 180 day before and after. And the last group for IFA is children less than 5 year. So in less than 5 year, we want to give least dose, of course. So to decrease the dose, we divide it into twice a week. That's why less than 5 year get it bi-weekly. Bi-weekly 20 milligram iron and 100 microgram folic acid. So again, this is very easy to remember. It is given till 5 year, and if you multiply 20 with 5, it will come 100. So this is for up to 5-year children, 20 milligram iron, 100 microgram folic acid. This is given in 1 ml IFA syrup bi-weekly, twice a week. So this is the complete dosing. I hope you will remember. Now let's come to discuss it. What are the point which you have said? Hello, hello, good evening dear. Hello Mansoor, hello Abhijit, Lokendra, Dipendra has given the answer also in the first question. It was A. First question answer was A, then he said C, very good. Ragnar was saying one thing, that in this question of thing, they said direct cause. Yes, that's why I said that this question was of direct cause of maternal death. Now, Ragnar was saying that preeclampsia was present in option. In place of heart disease, let's say preeclampsia was there. Okay. Ragnar is saying that preeclampsia was one option and they have asked direct cause. Okay, Dr. Ragnar. Now, yes, Atul Saini is also saying that preeclampsia they have written. Okay. Except wala nahi tha, direct cause tha. Okay, very good. Dr. Dipender Singh Chahal is also saying the same. Now, Dr. Ragnar, if preeclampsia was there and embolism was also there, then out of these two, embolism is a better answer. Because as I said, preeclampsia will first go into eclampsia and then eclampsia will cause maternal death. Preeclampsia, as you all know, it means protein which is +3 or more and systolic BP more than 140/90. Out of these two criteria, albumin and systolic BP criteria, the most important criteria is that if any mother have diastolic BP more than 110, then this is an imminent sign that now she will go into eclampsia. So, preeclampsia do not cause maternal death directly. They cause maternal death only when preeclampsia proceed to eclampsia, where we treat by magnesium sulfate injection. So, if preeclampsia and embolism are both in the answer, of course, the direct cause will be definitely embolism. And remember, anemia, diabetes, malaria, these all are indirect cause. Okay. So, Dr. Ragnar was angry on me. He said, no point of coming if you are not checking that. I was in my flow. Sorry for that. I will check it regularly now. Don't be angry. Okay. And Deepraj Desai is saying, sir, this question was not there. So, which question are you saying, Deepraj? Of course, this was there, that what is the direct cause of maternal death? Please clarify yourself, Deepraj. Okay, so now, I hope this part you will remember that in the indirect causes we have anemia, malaria, heart disease and all. And in the direct cause we have ectopic pregnancy, embolism, anesthesia related death and all. Okay? Chalo. So, now let's move ahead to the next question. If they ask indirect, then it is anemia, but as you all are agreeing, they have asked this question only. So, this was the answer. Embolism was the answer of this question. So, this was one of the controversial question other than less than or equal to 21. Now, after Anemia Mukt Bharat, this is one question which they ask from rule of half. They gave the image and they ask what is the centermost point is indicating. So, the centermost part is indicating those who are treated adequately. Adequately means they are treated and have proper control of BP and proper control over BP and blood sugar. Okay. So, what is this rule of half? I hope you all know that this is being given in PAAR also. This circle, bigger circle is representing the whole community. Half of them are normal, half of them are hypertensive almost, and in the hypertensive, half are undiagnosed. Out of those who are diagnosed, half are untreated, and out of those who are treated, only half is adequately treated. So the last line, last one is adequately treated. Okay, in the rule of half, adequately treated is the innermost point, is the adequately treated one. Okay, so that is there. If you go to rural area, many of them are having hypertension and diabetes, but they are not taking any medicine and all. So even if you are diagnosed, treatment is given to only half. And even if you will look at your parents, your uncle and other treatment card, you will find that they are getting treatment, but their BP sugar is not under control because they are not going for exercise and their diet control is also improper. So finally, only very less amount have adequate control over diabetes. So adequately treated is the last one. Okay. Now, John Lewis has one thing he written. A to E marking was given on circle and E marking was asked. So if you write A to E, it can be like this, that it is starting with A, B, C, D, E. A to E is given, and what is this last point? This last point is adequately treated. Okay. So answer remain the same, adequately treated. Very good, John Lewis, thank you for making it more correct. It is there. Now, what is the number of live birth per 1,000 women? This we have discussed in one of the session just before exam also, that many a time they ask total number of birth per 1,000 women and still student tick TFR. No, TFR means total live birth per female. If it is per female, it is TFR. If it is per 1,000 female, then it is general fertility rate. When they include the word 1,000, it becomes GFR. And if you remove the word 1,000, it becomes TFR, total live birth per female. और हम चाहते हैं हम दो हमारे दो, but we want we two our two, but the target TFR for India is 2.1. That means every female should produce 2.1 children. If you take average of a population, let's say I have 1 child, you have 3 child, someone has 0 child. So if you take average, it should come 2.1, because out of 2.1 some children will die. So finally it will come TFR equal to 2. Okay, but if they ask number of girl live birth per female between, of course, 19 to 49 year, of between maximum 15 to 49 year. This is the maximum age group. Minimum age group is 19 to 46. So number of girl live birth per female, if they ask, this is gross reproduction rate. And if they ask number of girl child per female, considering एज स्पेसिफिक मोर्टालिटी रेट, देखो जितनी बच्चियां पैदा होंगी सब तो नहीं बचेंगी, कुछ तो मर भी जाएंगी. आउट ऑफ ऑल द गर्ल चाइल्ड हु टुक बर्थ, सम विल डाई ऑल्सो. सो दिस वी विल, those who die, they will not produce more children in the future now. So the fourth is NRR. In NRR we subtract those girl child who die after birth. So these are the 4 parameters which we used, and I know this is confusing. So to make it clear and fix in your mind, let's discuss it with a story example which will make it clear. And remember, this is the formula being given also. Number of live birth per female per 1,000 female, if they ask, it is GFR. Okay. So to understand it better, let's have a story. Suppose there are okay, so suppose there is 100 young couples, okay, they went to jungle. क्यों गए जंगल? है ना, to do jungle mein mangal, है ना. They went to forest area of 100 young couple. Young couple means in which females should be between 15 to maximum 49 year child producing age group. And out of these 100 young couple, they are there in the forest for 3 years doing wild sex there, and they are without condom OCP, so they will produce some children. So let's say they produced 102 girls and 101 boys, and out of these, 1 girl and 1 boy, they were playing together and they jumped into well together and they died, okay, or tiger came and eat them together. So these, if you add 102, 101, this 203 will be the total live birth. And this girl and boy, they died before becoming adult, died before 15 year. Okay. So finally you have 101 girl and 100 boy. Okay. Now if I want to write general fertility rate, GFR, what is GFR? Total live birth per female. No. Total live birth per 1000 female. So what is the total live birth here? 203. And it is per 1000 female. So we multiply by 1000. Now how many females are there in this example? Female, these are girls. These are not adult yet. So these are not included in female. How many females are there? 100 couple are there. So how many female? Don't say 50, 100, because usually in one couple there is one female. So 100 couple, 100 female. So the GFR will come 2.03 into 1000. What is total fertility rate? Total fertility rate means total live birth per female. What is the total live birth? 203. How many females are there? 100. So TFR will be 2.03. Now what is gross reproduction rate? This is number of girl live birth per female. How many girl live birth occur here? 102 girl live birth. So 102 by 100, 1.02 will be the GRR. And you can see from here that GRR is almost half of TFR. This is a formula very useful because girl child is always half of total population. X and Y chromosome are 50-50%. So girl child will also be half of total child and boy child will also be half of total child. And if female feticide is not happening at all, then girl child will be half of total child. So this is a useful formula. Now the last is net reproduction rate. What is NRR? NRR is also total girl live birth per female, but this time we consider mortality rate. So what is the girl live birth? 102. How many female? 100 female. But this time we will subtract that girl child who died after birth. जो मर गई थी बच्ची 15 साल से पहले, उसको माइनस करेंगे तो ये आ जाएगा 101 by 100 रफली इक्वल टू 1 आएगा. और इसीलिए कहा जाता है कि इफ NRR इज इक्वल टू 1 देन वी विल हैव 2 चाइल्ड पर कपल. हम दो हमारे दो होने के लिए NRR 1 होना चाहिए. क्यों? क्योंकि आप यहां देख सकते हो 100 कपल के 200 बच्चे. यू कैन सी हियर 100 couple and roughly there are 200 children. So that means 2 child per couple will be there if NRR is equal to 1. And to get NRR equal to 1, we need to protect 60% couple at least from producing unwanted children. So to achieve NRR equal to 1, couple protection rate should be 60%. Okay, this is one very important area from which confusing question come again and again. Okay. Okay. Dr. Medic is suggesting me one thing, that there is one question missed in every recall, sir. It was the definition of target and option where goal, target, other two are unrecalled. Okay. Okay. So he was trying to say that there is one previous year question. Dr. Medic and other students who are joining me, please correct me whether this was the question or not. Which of the following is a time limited phenomena, is restricted by time, okay, or is not restricted by time? Option A, is it the target, option B, which is the objective, option C, is it the goal, or option D, is it the like these three options, let's say, is here. So out of these three, what will be the best answer? Target and objectives are always time limited. These are time limited. Goal can sometime be time limited, but mostly goal is the one which is not restricted by time. Like my goal is to become fit. For last 5 years, same goal. My target is that I have to reduce 5 kg per month. This is my target. And objective is that I want to be capable of running 2 kilometers after 1 month of exercise. So objective is also time limited, target is also time limited, but goal is usually not time limited. Yes, okay. Achievement in a time frame. Dr. Medic is saying achievement in a time frame, but he is also not clarifying on the language. So maybe if you will message me and all, I will update it. But this was one question which was not being recalled anywhere, and even I was not able to properly recall you. But if you come out with proper option, please help me. So which of the following is correct about triage? I think this one you must have done correctly. Red, ambulatory, is the one which is used for green. Red is the one which is life-threatening. This is life-threatening. Life-threatening means red are those who need surgery, life-saving surgery in less than 6 hours. Black are of course not one with minor injury. Minor injury can go into green, and a minor injury is also green, you can say. Black, we all know, is dead or moribund patient. Dead or certain to die, moribund. So these three are definitely right, definitely not wrong, okay. Sorry, these three are definitely wrong. So what is correct, they are asking. Actually, yellow patient are not definitely stable, but we can say that yellow are those who need surgery between 6 to 24 hours. So out of these four, A, C, D are definitely wrong. So that's why B is better option, preferred option of choice. Okay. Dr. Medic is thanking me for taking this question. No, Medic, I think I am still not able to get it clearly, but I was trying to come to some correct thing, and it's okay. I am not, thank you is not needed. You are listening, that is good for me. So what is the dose of vitamin A for 1 to 6 year child in endemic areas? For that, PAAR has written this thing very clearly, if you will see, that in less than 6 months, no matter what is the weight, we always give 50,000. Okay. In 6 to 12 months, if weight is less than 8 kg, then we give 1 lakh. And if more than 12 months and weight is less than 8 kg, whenever the weight is less than 8 kg, it is always 1 lakh. But when the weight is more than 8 kg, then we give 2 lakh. Okay. And it is written here. This line, if you will see, it is, they have clearly written that children more than 12 months but having weight less than 8 kg should be given 1 lakh. So first thing you will look is the weight. Weight less than 8 kg, 1 lakh. Weight more than 8 kg, then we will look at the age. If the age is more than 1 year and weight is also more than 8 kg, then we will give 2 lakh. And whenever you are treating someone for vitamin A deficiency, like measles cases or cases of vitamin A deficiency symptom, like conjunctival xerosis is the first sign of vitamin A deficiency. So in that cases, you will give 3 doses on day 1, 2 and 4, and we give oil based formulation as a treatment. Okay, and in every severe acute malnutrition child, we always treat with vitamin A also. So the question was not so confusing, it was a clear cut question actually. They were asking that after 1 year, if the weight is not given, what is the dose we give? So after 1 year, I hope you all know, we always give 2 lakh international unit, and this 2 lakh international unit is given every 6 months till 5 years of age. Okay, so it is 2 lakh international unit orally for 6 months, every 6 months till 5 years of age. Okay, so I hope you will remember, after 1 year 2 lakh, less than 1 year 1 lakh. But you have to look at weight. Weight is less than 8 kg, no matter what is the age, dose will become 1 lakh international unit. Okay, अगर 8 किलो से कम है तो 1 लाख ही देंगे, कुछ भी वजन, कुछ भी उम्र हो. और otherwise normally in 9 months we give 1 lakh, and then from 1 year to 5 years we give 2 lakh every 6 months. Urban healthcare is not included. Which of the following is not included in urban healthcare? Okay, so this is the again one flow chart which is useful for your exam preparation. In urban health center, urban health system, we start with MAS, तूफान उठा दे, महिला आरोग्य समिति, and in महिला आरोग्य समिति, they can ask the population norm. This Mahila Arogya Samiti is at 50 to 100 household, and every household has 5 members. So 50 to 100 household multiplied by 5 if you do, it is 250 to 500 population for Mahila Arogya Samiti. What is Mahila Arogya Samiti? This is group of female who hold monthly meeting in urban slum area, and then they report to USHA. USHA is also known as Community Health Volunteer, and one USHA is at 1000 to 2500 population. Okay, then USHA report to ANM, urban ANM, which is at 10,000 population. Urban ANM report to urban PHC, which is at 50,000 population. And urban PHC report to urban CHC, which is at 2.5 to 5 lakh population. And in NEET one time they have asked this question, that how many bed are there in urban CHC? So urban CHC, they have, if you see here, usually urban CHC or rural CHC both have only 30 bed. But if the city if it is in a metropolitan city, then there is 100 bed. So urban CHC is 30 bed, but at metropolitan city, urban CHC is 100 bed. Now one more question was, can you open urban CHC near a medical college or district hospital? Answer is yes. We can open urban CHC near medical college, district hospital. Less serious patient will come to urban CHC, more serious patient will go to medical college, but they can be opened nearby also. Okay, remember it. Now, so of course, I hope it is clear to all of you, and remember, urban PHC is at 50,000, urban CHC is at 2.5 to 5 lakh population. So do remember this population norm, this is very important. So you can see, USHA is not reporting to sub-centers, he was reporting to directly to urban ANM and then urban ANM to PSC. So which is not there, our sub-center is not there. Dr. Mansoor Alam is right, sub-center is not in urban health area. That's why Delhi have Mohalla clinic and Tamil Nadu have Amma clinic in slum area to compensate for the sub-center which is missing. Okay, we discuss it. Now in a chronic alcoholic patient who presented with loss of coordination, confusion, unsteady gait, which vitamin deficiency is there? Again, this is one which came in NEET exam recently, so we have discussed it in the session before exam also, that these all can be features of vitamin B1 deficiency. He might be suffering from Wernicke's encephalopathy. And to remember, the features of Wernicke's encephalopathy, the mnemonic is very good, Goa. G for global aphasia, he will not be able to speak properly. O for ophthalmoplegia, and A for ataxia, jhatka marega. Okay, so this happen in those people who are drinking alcohol for last 10-20 years, someone like me. And after chronic alcoholism, suppose I did not stop here and I keep drinking for next 20 years more, then I will go into Korsakoff psychosis. And in Korsakoff psychosis, there is confabulation. Confabulation means true lie. I will come in the class and I will say that in the morning I went for a jogging for 1 hour and then I am coming in the class. Actually, I was just sleeping. But I will come and tell you that I was in a jogging. So I am telling you a truth, but it is a lie. Actually, my mind is so messed up due to drinking alcohol that I am unable to differentiate what is a lie, what is a fact. And I am telling you true lie, that is confabulation. Okay, and do remember, if someone is chronic alcoholic and then leave alcohol for 3-4 day withdrawal, then he will have all these symptoms of anxiety, palpitation and all, and this is known as delirium tremens. How will you treat a patient of delirium tremens? Will you give him alcohol again? No, he will have all these symptoms. Do remember, they ask the question from symptom, anxiety, palpitation and all. So how will you treat a patient of delirium tremens? If you know, tell me in the chat box. Medic is saying we will give vitamin B1. Yes, Dr. Medic, you are right. We will give vitamin B1. But other than vitamin B1, we will also give benzodiazepine group of drug like tablet Alprax and all come in the market that we can give to relax him. Okay. So do remember this alcohol part come again and again. And this is due to vitamin B1 deficiency, and NEET they have asked it in a different way, that this vitamin B1 deficiency is due to what habit. So it is due to eating polished rice this developed. Okay. And due to eating polished rice, they can have wet or dry beriberi. In wet beriberi, the symptoms can be dyspnea and congestive heart failure. This was the question in NEET exam. Dyspnea, congestive heart failure, patient come with difficulty in breathing, and there was some pitting edema on dependent part like leg and also. So that all can be due to vitamin B1 deficiency. One more question which come from here, what is the enzyme which cause it? Which NEET exam, recently they asked it. So the enzyme is thymine transketolase enzyme. This enzyme deficiency cause this wet beriberi, and dry beriberi will have neurological symptoms. Okay, so that will be there. Now, oh, I have put all of it here. So rather than just going through my words, you can also read it here. We have discussed it, and it is written also that polished rice, if you see here, they have discussed polished rice is causing it, and there is dry beriberi, wet beriberi, infantile beriberi. Okay. And all the symptoms which was here, ophthalmoplegia, polyneuritis, ataxia, it all mental disorientation, this all occur in vitamin B1 deficiency. Prevention of vitamin B1 deficiency is not eating polished rice and to stop alcohol. Okay, plus we should supplement vitamin B1 in lactating mother. That is what they have written as treatment. Okay, chalo. Now, in an experiment, 39 was highest number but was mistakenly written for 93. What will be its effect? So let's take that distribution. Suppose the distribution is 10, 15, 20, 25, 39. But what we did was, in place of writing this, we write 10, 15, 20, 25, 93. So in these two distribution, what is the median? Median is simply the middle number after arranging number. After arranging whatever the middle number, that is median. and we can see in both of them there are 5 5, so the middle number is 20 here, 20 here. So that means median will remain same. This is a correct answer for sure. Median remains same. Median will not fluctuate because median is in the center, so it is not affected by big number. If any big number is there, median do not get affected. Who get affected? Mean get affected. Mean is actually mean minded. Whenever it get big number, it get dragged towards it. So let's find the mean of the first distribution. Mean is found by adding all the number, dividing them by sample size. Sample size is 5 thing are here. If you add them, 15, 25, 40, 10, 20, 30, 40, 30, 70. 70 and 39 is 109 by 5. So it will be 21.8. Okay. Now, if you add the other part, it will be 25 and 15 again 40 and 30, 70, 70 plus 93 by 5. So if you do 70 plus 93, it will become 163, I think. 163 by 5 will be roughly how much? 32.6. Okay. So you can see in this first case mean was 21.8. In the second scenario mean become 32.6. So if I am changing 39 with 93, I am changing by big number, mean will also become big. So if I am replacing a small number with big, mean will increase, median will remain same. D is the answer. Okay. My dear friends, do you all agree? Chalo, please do answer. Whenever you feel the answer, please do answer it. Now, next question is, which international agency help in construction of sanitary latrine? I am sure you must have read by now the answer to it. The answer is Ford Foundation. But as I said, my target is that all the topics which are difficult and which need detailing should be dealt properly. So let's discuss it in detail. What is the work of Ford Foundation? Ford Foundation, as you can see, it work for sanitary latrine. So that's why they are saying designing and construction of hand flushed acceptable sanitary latrine. This is one work. Second word, along with sanitary latrine, the second work of Ford Foundation is NIHAI. Nihau nahi, NIHAI. What is NIHAI? NIHAI means National Institution for Health Administration. Health Administration and Education. So, health administration and education is again one more work which is done by Ford Foundation, sanitary latrine and formation of NIHAI. Okay. So these are the two main work written. And then the Calcutta city drainage system was also being formed by NIHAI, by Ford Foundation. So NIHAI, sanitary latrine, anyway, नहाना, निहाई नहाना और मैदान जाना, दिशा फिरने जाना, ये साथ में होता है ना जनरली गाँव में, है ना. निहाना means taking bath and latrine is together. So NIHAI and latrine both by Ford. And if you are doing NIHAI and latrine, the water will go in drainage system. So drainage system, NIHAI means taking bath, latrine, all are related to Ford Foundation. Okay. Ford कार में आप बैठ के नहा रहे हो, दिशा फिर रहे हो, झाड़ा फिर रहे हो और ड्रेनेज सिस्टम भी ठीक कर रहे हो कलकत्ता का, है ना. सो सैनिटरी लैट्रिन, निहाई, ड्रेनेज, ऑल थ्री इन Ford. Okay. Now, Red Cross was formed to help the war victims and all. So it is for first aid, it is for blood donation. You must have seen blood donation camp by Red Cross, and it is for war relief. All the things which happen in war is here. Again, एक चीज आप देख सकते हैं. During war, we need more blood transfusion, blood donation, and during war, we need more first aid. So war, first aid, blood donation, all by Red Cross. Okay. Then Rockefeller Foundation. Rockefeller Foundation have formed National Institute of Virology. NIV is formed by Rock Foundation. Second, Rockefeller Foundation. Second thing is Rockefeller help in training of teacher, and it is also formed Institute of Hygiene and Public Health in Kolkata. All India Institute of Hygiene and Public Health in Kolkata, and National Institute of Virology is formed by Rockefeller. So Rockefeller, you can see, you can remember it like this, that you are so dedicated that you are in a mountain area and still you are studying and all. Rockefeller is focusing on study part, education part. That's why it has Public Health Institute at Kolkata, Public Health Institute, National Institute, and it also fund the National Institute of Virology. Two things by Rockefeller Foundation. Other than that, in CARE Foundation, the work is focusing on improving nutrition. You are taking care of malnourished children. So CARE is related with ICDS, Anganwadi, and all this nutrition related work is CARE. ICDS program is CARE. Care of newborn child. FOD, you are taking bath, knee-high, latrine and sewage system. Red Cross with war, first aid and blood donation. And Rockefeller with studies, so Virology Institute and Public Health Institute by Rockefeller. I hope you will remember these organization. Last, in NEET they have recently asked the Colombo plan. Colombo plan does three main things. First, which was asked in the exam, it form cobalt therapy unit by taking fund from Canada. C for cobalt, C for Colombo, C for Canada. So Canada fund cobalt therapy unit of Colombo plan. Second is Colombo plan also opened AIMS New Delhi by taking fund from New Zealand. Third is, more importantly, Colombo plan focus on industrial and agricultural development. This is the main work of Colombo plan. Okay. Now, what is SIDA and DANIDA? SIDA fund TB program of India. This is Swedish International Development Association, and DANIDA fund eye program of India. So how will you remember it? देखो, दान करते हैं आंखों का, नेत्र दान. So eye donation is here, eye दान, eye donation, and S for SIDA, S for sputum. So SIDA fund for TB program, S for SIDA, S for sputum. Okay. So do remember these funding organizations. Other than that, there is some other funding organization which we should revise quickly. USAID fund for malaria control program. UNDP fund for sustainable development goal. UNFPA, United Nations fund for population activity, fund for family program, family planning program. देख रहे हो, नाम लिखा है फंड फॉर पॉपुलेशन एक्टिविटी, है ना, लेकिन पॉपुलेशन एक्टिविटी यानी सेक्स के लिए पैसे नहीं दे रहा है. इट इज गिविंग मनी फॉर पॉपुलेशन कंट्रोल एक्टिविटी. ओके, फैमिली प्लानिंग प्रोग्राम. एंड दिस थ्री दे हैव आस्क्ड. देन यूनिसेफ, it fund maternal and child health program, and along with funding maternal and child health program, it also fund seed and manure of applied nutrition program, which was asked in NEET exam, of applied nutrition program. Okay, so these organization you must revise again and again before exams. Now, a pregnant woman whose mother have diabetes came to sub center for screening. When she should be screened? At 20, 24, 28 at first visit. So it is written in PAAR also that for gestational diabetes we should screen in second half of pregnancy. What is the correct answer? What do you think? Please answer it. What is the correct answer? The best answer out of these will be 28 week. If one option asked, it is 28. But some students were saying that no, it was not like that, it was in the range. So if it is in the range, answer will be best will be 24 to 28. But if they ask you one answer, it will be 28 week. Okay. Now, it is written in the PubMed guideline also that screening is done between 24 to 28 week of gestational, because it increases during second trimester and in the first trimester, placental hormone lead to insulin resistance. So generally diabetes occur in second trimester and we should screen between 24-28, but best is 28 out of that. Okay. Now then next confusing question was this: identify the graph below. Was it a point source, was it a common source continuous exposure, or was it a propagated epidemic? So let's go at the basics and then we will come back to this question. What is a point source outbreak means? Point source means cases occurred quickly and fall quickly, and the time taken is less than or equal to 1 incubation period. All cases occur within some days or some hours, within 1 incubation period. Like in case of Staph aureus, the incubation period is 2 to 6 hours. So all cases should occur within 6 hours. Then we will call it point source. The other name of point source is common source single exposure. And a very good example of common source single exposure is Bhopal gas tragedy. The second example can be the food poisoning at your hostel and all. So if you look at the graph of point source, they started the epidemic by 29th of April, and the last case came on within like 29th of April they started, and then 20 September the last case came, and this is hepatitis A epidemic they are talking, because in case of hepatitis A the incubation period is 10 to 50 days. So if all cases occur in less than 50 days, only then we will call it point source epidemic. And here you can see all cases are coming within 20-30 days. Okay. So if cases are coming close to each other, that is point source, and if you draw an imaginary plot also, you can see it is something like this: quick rise, quick fall. So if such type of thing is there, it is common source single exposure or point source. Common source single exposure is same as point source. Now if you look at this continuous common source, in continuous common source cases rise quickly and they fall quickly, but the cases can keep on fluctuating. This is a good example of common source continuous. It keep on fluctuating. Okay. And the cases take month, like August to October. And a big duration is usually there for common source continuous exposure. If we are talking in hours and days point towards point source epidemic. But if it is in month, it is usually continuous. Now let's look at the last propagated epidemic. So for propagated epidemic, again the duration is big, but main thing is propagated epidemic have secondary wave of cases. So if you find one wave and then the another wave like this, secondary wave is there, that is propagated. Propagated slowly rise, slowly fall, and then there is secondary wave of cases. And example of propagated, you all by now be very easy to answer. Secondary wave which occur in corona also, SARS, MERS and all, that will be there. So propagated is like this, 2 wave. Continuous exposure is with fluctuations, and the fluctuations, if it is not touching baseline, it is continuous. If the fluctuation touches baseline, then it become multiple exposure. If it touches baseline and goes up like this, it is multiple exposure. And in both continuous and propagated, duration are in month, but in point source, duration of occurrence of cases are in some days only. So let's do this question which will make it more clear. If you can do this question which you can see on the screen and answer it, I will be happy. The graph shown here is an epidemic curve of a real outbreak, Salmonella, which occur in Massachusetts, and Salmonella has incubation period of 1 to 3 days, they have written. What kind of epidemic curve is this? And they started with 13 May, maximum case occurred at 16 May, so 13 to 16. What is the answer? What do you think is the answer of this question? Is it a point source? Is it a continuous? Is it propagated, or none of the above? So, how to answer this question? Step is, first focus on incubation period 1 to 3 days. If cases come in one incubation period, it is point source epidemic. If cases are coming in, let's say 30-40 days, it can be continuous. If cases are coming in 3-4 months, it can be propagated. So here, very good Mithu Kumar, thank you for answering. Dr. Mithu Kumar, you are absolutely right. Very good. The cases are coming between 13 to 16. So within 1 to 3 day cases came, and incubation period was also 3 days. So that means it is a point source epidemic. Dr. Mithu Kumar was absolutely right. Now, let's come back to our question and see how the things are going. Index case came at 4, and then the cases slowly rise, and then the cases slowly fall. So this is again a typical feature of a propagated epidemic, and you can see the days are there. If it would be rise again, that will be a secondary wave. But even without secondary wave, if cases are slowly rising and then slowly falling, it is propagated. Okay, because in common source continuous cases will rise quickly, then fluctuate and then fall. In point source cases will rise quickly, then fall quickly. Okay, but in propagated it will be like this. So that is here. And I gave you multiple graphs so that in next exam if they change the graph, still you will be able to answer it. Chalo. Now, okay, let's have one more better look. This one question will help you more. In this two thing, here cases started and then they almost fall like this. In the second, cases started and then they went like this slowly. So this one is propagated because you can see here October to January cases are occurring in month, so it cannot be point source, and it is written here also it is propagated spread. But if, and this was the same graph given in the exam, this was the same graph, that's why every teacher is also teaching you the same thing, that it is propagated. But if it fluctuate like this, quick rise and then fall, then it will be point source. Okay, so this is the graph which came, and I hope from graph question you can answer the things now. Okay, propagated is like this, point source is like this. Now let's move to next question. A 10-year-old girl came to health checkup. She does not go to school. Which of the following program will benefit her? And many students, they say that there was an option of ICDS program also. So she is not going to school. That means midday meal program will not be able to help her. And then some students say that school health program was an option. So a school health program does not directly deal with nutrition. In a school health program, as you all know, one teacher screen children and then refer them to higher center if they have visual acuity less than 6/9. And a school health program come under PHC Vision Center. Okay, PHC also does the work of screening, and in school health program, teacher is doing the screening. So because both of them are doing screening, so that's why school health program come under PHC. But it does not directly deal with nutrition. And if they would have talked about nutrition thing, ICDS could have correct. But they are saying that the girl child is coming for health checkup. If she is coming for health checkup, which program will help in doing health checkup in a 12-year-old kid? 10-year was some people saying, some were saying 12. It does not matter. The answer will remain same. राष्ट्रीय बाल स्वास्थ्य योजना, बाल स्वास्थ्य कार्यक्रम, है ना, बाल स्वास्थ्य कार्यक्रम. सो कैसे रखोगे ख्याल अपने बालों का? हाउ विल यू टेक केयर ऑफ योर बाल? तेल लगा के? You can. But in this RBSK program, I hope you all be knowing, there is 4D which come. Defect since birth, deficiency disease, developmental anomaly, okay, like my case, developmental anomaly, and last D is disease of childhood, बचपन की गलतियां नहीं, बचपन की बीमारियां. Okay, so आंगनवाड़ी, ASA and Ayush doctor, all three of them are part of RBSK program. ASA do home visit and screen child and mother and refer them to higher center if needed. This was the question which came in NEET exam, that in a village people are not taking papaya and mango in pregnancy. So who will screen them and refer to higher center? Answer was ASA. ASA visit home and screen children and refer to them to higher center. Okay. So ASA does screening of children and mother and refer. Then Anganwadi at Anganwadi center can do the screening. And finally Ayush doctor will go to school and do the screening. So if the lady do not come to school, then she can get her health checkup even done at Anganwadi. And for health checkup, the answer will be RBSK. But if they ask that a 10-year-old child came for food and she does not go to school, then where she will get food? If they ask health checkup, answer is RBSK. But if they ask a 10 or 12-year-old child need food, which program will help her? Then the answer is ICDS, because under ICDS, Anganwadi program come. So if she need help in food, ICDS will help her. If she need help in health checkup, RBSK will help her. Okay, do tell me what was the answer. Question, is it correct which I had recalled, or was it something different? If you know, please help me out. Okay, so do remember it. So this is one short clips of RBSK which you all should know. The things about RBSK, it is for 4D, and as I was saying, ASA can do the screening, Anganwadi can do the screening, and then government school will have the mobile health team in which Ayush doctor will be there. He will do the screening. And remember, total there is a list of 30 diseases which come under it. 30 diseases come under it. But congenital glaucoma is not written in the list. That do not come under it. And zinc deficiency also not written here. Both of these diseases don't come under RBSK. Because in RBSK, Ayush doctor and all Anganwadi worker are doing the screening. So they are doing the screening without any instrument. And congenital glaucoma and zinc deficiency can be diagnosed superficially only in 10% of patient. Rest of the other patient, they need instrument to detect it. That's why these two do not come under RBSK. What are the two? Congenital glaucoma, zinc deficiency don't come under it. Okay. Now, next question. Which of the following assess chronic malnutrition for height for age? Chronic malnutrition is height for age and it is by stunting. Wasting is low height for weight. This is one confusing thing. Low height for weight means we will be writing height of the child which patient which came to us. No, this is not low weight for height, this is low height for weight. This is chronic malnutrition. This is low weight for height. What does it mean? Low weight for height. Let's understand it meaning wise, then we will not confuse. Whenever we are measuring low weight for height, we will write weight of patient above and divided by weight of expected weight of patient, expected weight of the person who came at that height. मतलब वो जितना लंबा हो गया है उसके हिसाब से उसका वजन कितना होना चाहिए. एक्सपेक्टेड वेट अकॉर्डिंग टू हाइट of patient. For example, suppose someone is very tall and very thin. So the weight of the patient is less as per the height. And इसी को this is known as wasting. बंदा सूख गया है. Why wasting happened? He got good nutrition since childhood. So there is no chronic malnutrition. Chronic part is good. But now for last 1-2 months, he or she might have fallen in love, or some breakup has happened and they are not eating well, or some exam stress is not letting them eat well. So because of that, they are wasted. So wasting indicate acute malnutrition. Okay? And it is, wasting simply means the person weight for height is low, low weight for height. But what does low weight for age indicate? Low weight for age indicate both acute and or chronic malnutrition. Okay? For example, imagine me as a malnourished child. I know it's difficult, but try to imagine. I am very malnourished. So I can be malnourished due to two reasons. One reason, my mother is not giving me food since birth. So that is chronic malnutrition if mother is not giving me food since birth. Second, my weight can be low because my wife is not giving me food for last 2 years. So that is acute reason. So the weight of a child can be low due to acute reason or chronic. That means it can be any one of them. Or there is a chance that my mother and wife are planning together to keep me malnourished. So they can be together or they can be separate. Okay? And or means acute and chronic can work together, or acute and chronic can be separately, leading to low weight for age. So do not miss this part. This is very important. We have discussed it again and again in the session also, that it was there. And we discussed one more thing there. It was not in the question, but we discussed that if it is SAM, severe acute malnutrition, then what is the criteria for mid-arm circumference of SAM? It was 11.5 centimeter is the criteria for mid-arm circumference of SAM. And for SAM, we measure weight for height, which should be less than -3 standard deviation, not -2. Less than -3 weight for height is SAM. And I think this was the exact question which came in your exam also. Okay? Height for age they have said, so height for age is indicating chronic malnutrition. And in one of the NEET exam they have asked that if any child is coming between -2 to -3, then what will you call it? Mild, moderate or severe? -2 to -3 is moderate, below -3 is severe. That's why SAM is less than -3 weight for height. Okay? And SAM means severe acute malnutrition. Mid-arm circumference should be less than 11.5. Okay? Sure. So now Dr. Mac Logic is saying that in that question of the girl child, the question was that a 10 or 12-year-old child, and it does not matter because in Anganwadi and in RBSK also we do cover in Anganwadi till 10 to 19-year adolescent girl come, and in Rashtriya Bal Swasth Karyakram till 18-year children are being screened. So whether it's 10 or 12 does not matter. So a 10 or 12-year-old girl child, okay, came for health checkup was not there according to Dr. Mac Logic. Came for health checkup was there. But after health checkup, came for health checkup and She was found malnourished. Wow. She was found malnourished. And she is not going to his school. So which program will help her? Okay, this was the real question. She is not going to school, then which program will help her? So in this case, option A, RBSK, Rashtriya Bal Swasthya Karyakram, will not help her because this is a screening program for 4D. Remember, it is not giving nutrition. Second is, let's say, school health program. School health program do not directly deal with nutrition. Nutrition part is, in the past it was dealt with midday meal program, but now midday meal is known as PM Poshan, and it do not come under ICDS anymore. PM Poshan come under Ministry of Education. Smriti Irani is head, our education minister, and she is looking over this program, PM Poshan. The last option, if it is ICDS, of course the correct answer will be ICDS, because ICDS deal with Anganwadi program, and in Anganwadi 10 to 19 year adolescent girl can get nutrition, and therefore they can have this malnourished gone if they are taking nutrition there. So then the answer will definitely be ICDS program. Thank you Dr. Mac Logic for correcting it for the class. Do focus what they are asking. If you remove this word, she was found malnourished, then answer can be RBSK. But if it is written she was found malnourished, answer definitely is ICDS, and I am sure Dr. Mac Logic is correctly identifying the question, and it was written, so the correct answer was ICDS. Very good. And as you can see, in FMG exam, recalls are never perfect, because after first session all the students are in mood to give second session. Now they are not focusing on recalling, and after second session they are in mood of partying now, because they have worked hard the whole day, so they want to relax now. And after party, who can recall? So that's why I emphasize again and again that if you are going to give FMG exam in future, do not just do 5 year of FMG solution. Along with 5 year of FMG solution, also do 5 year of NEET, because NEET exam is of only one session. Many teachers also give the exam, and the recall of NEET exam is really very good. So if you will do 5 year NEET, it is only 1000 question, but that 1000 question will give you a real scenario how exam question are twisting this day. And many a time, as I discussed, in this time in PSM only, out of 2020 NEET exam, directly 3 to 4 questions were repeated. So NEET and FMG, they repeat each other question. In FMG exam, last time they asked about this estimated average requirement, which fulfill need of 50% of patient. And then in the NEET also they ask the same, that what is the difference between RDA and estimated average requirement. RDA fulfill need of 97% or 97.5% population need is fulfilled by recommended dietary allowance, and estimated average requirement fulfill need of 50%. That was the question asked in FMG, then NEET copied it. So you have to do both of it, and they exchange the question also. So RDA will always be more than estimated average requirement. Okay. Now next question. Yes, very good. Next question is, what is the criteria for mid-arm circumference for severe acute malnutrition? It is definitely 11.5 centimeter. For SAM, it is 11.5. Second criteria, as I discussed, less than -3 standard deviation, weight for height. And remember, weight for height indicate acute malnutrition. The third criteria was visible wasting or stunting, or pitting edema present. So these three criteria is the criteria for SAM, severe acute malnutrition. HIV patient come for diagnosis. What is the first diagnosis you will do? What is the first test you will do? So in 5 patient, HIV, COVID-19, diabetes, previously treated TB. If someone has been already treated by TB in past for more than 4 weeks, then they are called as previously treated. More than 4 weeks is previously treated. More than 4 week ATT drug someone taken, that is previously treated. And the 5th is pediatric TB case. Because you all know, in children, if you ask them कि थूक दो, तो वो मूत देंगे, है ना? They will not spit properly. So in 5 cases, we do not go for ZN smear, we directly go for CB-NAT. Okay, we have discussed it in the session before exam also. And what is the gold standard for TB diagnosis? Culture in liquid medium, not CB-NAT. CB-NAT is not gold standard test. Gold standard test, culture in liquid medium in Mycobacterium growth inducer tube. This is the gold standard for TB diagnosis. And if they ask the question that which test help us to know the spread of TB? Spread of TB. So spread of TB will cause only infection. It will not cause disease. When we are malnourished, then infection go into disease. And infection is best detected by tuberculin test. In a population, if we want to detect it, then tuberculin test is the best. So spread of TB is best detected by ARTI, annual risk of tuberculin conversion. ARTI they say, an annual risk of tuberculosis infection, okay, by tuberculin test. So spread by ARTI, TB disease by CB-NAT, in all these 5 by CB-NAT. But if you want to screen for TB in the whole population, then ZN smear will be better. In the whole population, screening is by ZN smear. Okay, and gold standard is TB in culture medium, culture in liquid medium is the gold standard for TB diagnosis. Next question, which is correct regarding disposal of expired tablet? I hope you must be knowing that in red bag we have plastic. So plastic go through recycle. First we will do autoclaving, then there is recycling, so that we cannot burn plastic. It will produce large amount of pollutant. Blue bag, we have metallic instrument and implant. And metallic instrument and implant we want to reuse. So we cannot burn it. Incineration means burning in air. So here metallic instrument implant and glasses, they all first go for autoclave, and autoclave we reuse them or recycle them. Correct answer is definitely yellow bag, which go for incineration. And they have asked in past also, incineration is done for which category? Yellow bag. So do you remember, if they ask plastic wrapper of syringe, plastic wrapper is not contaminated with blood, so that will go in black, because black is for garbage. But other than this, any other plastic will go in red except blood bag. One more thing which do not go in red, blood bag, that also goes in yellow. Okay, chalo, next question. School health program come under, we have just discussed, school health program come under PHC Vision Center, because PHC also do screening and school health program also do screening. But some students say that this was not the question. The question was, which I have put in the end also, that school health program comes under which of the following program? And option A was Ayushman Bharat. Option B was, let's say, RBSK, Rashtriya Bal Swasthya Karyakram. Option C was Rashtriya Kishore Swasthya Karyakram, Adolescent Health Program. And option D was NSSK, Navjat Sishu Suraksha Karyakram. So what is the correct answer if A, B, C, D is there? If you know, please answer. So school health program come under Ayushman Bharat. I will show you a slide from PAAR also later on, and they say it is under Ayushman Bharat. Okay, so it comes under PSC, it also comes under Ayushman Bharat program. Dr. Tausif Ahmed is saying, सर वहाँ 11 भी था. कहाँ 11 था? Tausif bhai, where it was 11? अच्छा, the age group 10, 11, 12 is okay, same, okay, I think. So remember, school health program come under PHC Vision Center and under Ayushman Bharat. Recently in 2018, it has been included in Ayushman Bharat. Okay. Chalo, next question. According to Sustainable Development Goal, what is the target of maternal mortality ratio? Maternal mortality is not a rate, it is a ratio. And the target for MMR is less than 70 per lakh. Other two target are less than 12 per thousand should be the neonatal mortality rate, and less than 25 per thousand should be the under 5-year mortality rate. तो आपको बस 3 नंबर याद रखना है, 70, 12, 25, 70, 12, 25. There is no target for infant mortality rate. 70 MMR, 12 neonatal, 25 U5MR. Okay. Other than that, the target is reduce premature cardiovascular death to 1/3 and eliminate. And now the party was ending and everyone was high on alcohol. So they say, someone asked, what about HIV? They say, eliminate it. They say, what about TB? Eliminate it. Malaria? Eliminate it. Eliminate all disease which is occurring in poor country like India and which is neglected by the developed country. So that is neglected tropical disease. All these 5 target is to be achieved by 2030. For 2020, there was only one target, reduce accidental death to half. And in 2020, Corona came. So accidental death actually became half. एंड एसडीजी वालों ने बोला कि देखा, बोला था ना कि अचीव कर लेंगे, और तुम लोग कह रहे थे कि दारू पी के फेंक रहा है ना. सो दे एक्चुअली अचीव्ड ओनली वन टारगेट फॉर ओनली 1 year, दैट वाज दिस 2020 accidental death half. Okay, so do remember the number 70, 12, 25. So the correct answer is none of these, of course. It should be 70, less than 70 is MMR target. Now, next question was, which of the following is not included in Ayushman Bharat scheme? So Ayushman Bharat is giving 5 lakh, not 10 lakh. So 5 lakh is included, and along with 5 lakh, health and wellness center is there, 5 lakh is there, but 10 lakh is not there. And this is given for economically weaker section who are earning less than 10,000 rupees per month for a family of 5 people. And is it for private hospital or government? Remember, Ayushman Bharat is for both government and private hospital, secondary and tertiary level hospital. Health and wellness center is, government is saying that 1.5 lakh sub center and some PHC will be upgraded. And after upgrading it, we will make it health and wellness center. So in upgradation, what are the new thing they are adding? First new thing they are adding is ENT facility, which is not even at CHC. Second is they will give mental health. Again, psychiatrist is not even at 1 lakh population, not even at CHC. So it's very difficult to make this thing available. Third thing they say is NCD treatment and all. But NCD treatment is already being given at sub-center and PHC in many of the places. Fourth facility they say dental health. And then finally they said that the main thing we will give is yoga and meditation. Kyunki yoga se hoga. Okay. So that is the 5 new benefit they will add, and they will change the name of sub-center and PHC into health and wellness center. Okay. This is one target of Ayushman Bharat. Okay. Now, these are the questions which actually we have discussed in the class. So I was being expected that I will show you in the slide, but I said rather than showing you these things in the slide, let's discuss about this thing the if I will take you the PAAR picture and discuss it, that will be more useful. Now let's come to discuss a post-coital contraceptive. All can be given except. So levonorgestrel we can give 0.752 time, and in one of the exam they asked the dose of levonorgestrel in eye pill, that is 1.5 milligram. Ethinyl estradiol is 50, and then we can give again 2 tablet after 12 hour, that is also correct. Mifepristone 50 start within 72 hour, dose may not be right, but mifepristone we give, but we never give centroman in post-coital contraceptive. So let's discuss what are the post-coital contraceptive together. Best is IUD. IUD is best because it protects till 5-day protection. So ideal is IUCD, I for IUCD, I for ideal. Okay. Second is hormonal, and you can see they have written levonorgestrel 0.75 tablet we can use within 72 hour 1 tablet, and then after 12 hour of second tablet. Okay. Second way they have written is what is given there, 50 milligram ethinyl estradiol within 72 hour and then repeat after 12 hour. So this is second method they have discussed, and a 0.75 milligram levonorgestrel and repeat after 12 hour. So what I am trying to do is, there was actually 2 questions on post-coital contraceptive. So I want you to remember all the 5 post-coital contraceptive which we can give. First is IUCD, second is LNG, third is ethinyl estradiol 50 and then again 50, fourth is 30 or 35 milligram ethinyl estradiol. But in the earlier case we are giving 2 tablet, and here they say give 4 tablet. Okay, and then similarly repeat after 12 hour. So that is also there. Now this is the fourth one. The fifth one, mifepristone is 10 mg. I told you the dose was not 50, dose is 10. So fifth is mifepristone 10 mg. Okay, and then you can also say levonorgestrel 1.5 milligram in eye pill and all. So we do not give post-coital contraceptive by centroman. Centroman is a non-steroidal and non-steroidal OCP prepared by India. It comes in India by the name of Chaya. C for centroman, C for Chaya is non-steroidal OCP. Do remember. Now, 32-year male presented to emergency ward following crush injury at hand. He had received last TT injection at age of 25. Wound cleaning is already done. What is the next management? So there is a recently updated guideline in the PAAR recent edition. This is all the images I have taken today is from this 27th recent edition of PAAR. So in that 27th edition, it is also written, do remember that one ASA is at 1000 population and minimum education of ASA is 8th class. Okay, it's not 10th class is not minimum. 10th class we want, but we accept 8th class also if no 10th class found. Okay, so these two is being written 3 places in recent edition again. Now let's come to this question. What is the PAAR is dealing with it? PAAR is saying simply that one type of wound is clean wound. If it is clean and in less than or equal to 6 hour patient come, then it is separately done. Other than clean and less than or equal to 6 hour, we deal it separately. Okay, how we deal it? First thing is in both the cases we ask, have you taken last booster dose in 5 year or not. 5 year is the question with clean also. 5 year is the question with other. 5 year is the question with other wound other than clean and in 6 hour. Now, if the answer came yes, I had completed course of toxoid or booster dose is taken within 5 year, then we treat like A. What is A? In case of clean wound, nothing is needed. In case of B wound also, which is not clean and not within 6 hours, if someone has taken TT booster in 5 year, then again it is written nothing more required. Okay, this is a bit controversial because WHO say whether if it is dirty wound always give 1 TT, but PAAR is saying that nothing is required even if it is dirty wound and in 5 years they have taken 1 booster, then nothing is required. Now, but this is the recent PAAR guideline, and being a PSM teacher I am relying on it and discussing it, and in Indian exam you have to answer accordingly. Now, second thing is, if he had taken some TT booster between 5 to 10 years, so in the case of clean wound we need 1 toxoid. In the case of dirty wound or after 6 hour coming wound also we need 1 toxoid, same thing. Now, if the person has taken the booster more than 10 years, then here we give toxoid 1 dose more than 10 years, and here we give tetanus immunoglobulin. So, in more than 10 years, we add tetanus immunoglobulin. Okay. Now, the last is, if person said, I do not remember whether I had taken tetanus in birth or not, whether I have taken my TT in 5 year, 10 year, I don't remember. If they say no, I don't remember, then in case of dirty wound, we give 1 TT, and along with 1 TT, we also give human immunoglobulin. The dose of human immunoglobulin is asked in one of the exam also. It is 20 international unit per kg. If it is horse immunoglobulin, then it is 40 international unit per kg. So, toxoid complete course is given only if no history is given, and whether it's clean wound or dirty wound, if no history, toxoid complete is given in both. In case of dirty wound or more than 6 hour wound, along with toxoid complete course, we also add human immunoglobulin. Okay. So, this is the criteria given, and remember, we are using immunoglobulin only if wound is not clean. We do not use tetanus immunoglobulin if wound is clean and patient came within 6 hours. So, with tetanus immunoglobulin is used only if wound is not clean or wound has taken more than 6 hours to come, or patient has forgotten about the history or had taken the booster TT 10 years back. So, in this cases, taken booster TT more than 10 years back or forgotten the history. In these cases only we give tetanus immunoglobulin. So, tetanus immunoglobulin not given in clean wound who come within 6 hours, no matter what is the case. In case of not clean wound not coming in 6 hours, if the patient has not taken TT in last 10 years, not 5 years, 10 years, and if the patient do not remember the history, only then we give tetanus immunoglobulin. So, now coming back to our question. In this question, very good. In this question, Dr. Mac Logic is happy that I am taking the question from his word and correctly saying that he give it correctly in the exam. Yes, Mac Logic, you were right. ICDS was correct answer there in that question. If that was the correct language which you are saying, and I am sure you are saying correct. So, ICDS was the correct answer in that child health thing, who was malnourished, who came for health checkup, detected malnourished, she was not going to school, so it was right. So, coming back to here. In this question, first thing is, Injury in hand they have written, but they have not written the timing. But if they have written the timing and it is less than 6 hour, then the cases will be like clean wound. But it is simply crush injury. So timing is not important here because it is anyway crush injury. We cannot classify it as clean wound anyway. So timing irrelevant, but main thing that relevant is what is the gap. 25 year here, 32 here. So the gap is 7 year back taken TT booster in dirty wound. 7 year back taken TT booster in dirty wound. So because it is 7 year back TT booster, not more than 10 year. As I said, more than 10 year, then we give tetanus immunoglobulin. But it is 7 year back, so we will not give immunoglobulin. Okay, we will give TT only dose, option A. It is very controversial because this guideline is different than WHO. I know, I can agree with your confusion here, but if you will go to the PAAR classification, then in this case we will give TT only. Of course, in 10 to 16 year, 10 and 16 year age group, at this time we give DT. But if someone is coming with trauma injury, then we don't need to give DT, we will prefer TT. So this option B and D are anyway ruled out. We have to discuss only between A and C. Let me go back and show you what was there. If you see here, they are writing it in this page. Other wound means dirty wound. And in dirty wound, till 5 year, the management is same, nothing required. If it is between 5 to 10 year, again the management is same, toxoid 1 dose. So you can see it is written B. B is toxoid 1 dose. And what is B? B means he has completed course of toxoid or a booster dose in 5 year ago and less than 10 year. So between 5 to 10 year, the management and the question is same in both clean and dirty wound. When we come to more than 10 year back, then in case of crush injury, dirty wound, we give immunoglobulin. And in clean wound, we don't need immunoglobulin. And if this person say, I don't remember the history, then we give the full course of TT. So here, it is not more than 10 year, it was 7 year. That's why we cannot give immunoglobulin. And if immunoglobulin is removed, only answer left is option A, TT only. Okay. So do go through this flow chart which is I am discussing and then answered according to this flow chart. Next question. All are given as emergency contraceptive except. So Ulipristal is an old contraceptives which was written in previous edition of PAAR, but in recent edition they have removed it. But still we can use these three, but after 14 days if you are giving something, it cannot be emergency contraceptive. Maximum we can give up to 5-day IUCD. And so of course D was wrong. Anthrax is which category bioterrorism agent? Very simple to answer. A for anthrax, category A. Category A means extremely. This time if they have asked anthrax, next time they can ask the other. So let's remember it. Extremely infectious is category A. And under category A, we have anthrax and botulinum, A and B. Can you remember it? A, B together, anthrax, botulinum. Other two are those which are the disease of the past, not discussed much more now. So plague and smallpox. Okay, P and S, plague, smallpox, the two old disease are also in category A. Then we have Ebola and Marburg. Kaun bola? Ebola and Marburg. These are viral hemorrhagic fever. Viral hemorrhagic fever means they also occur by eating fruit bat, and then after fruit bat it transmits from one person to another through their semen, saliva, sputum and all those things. But In Ebola Marburg, internal bleeding occur and patient die. It is not due to respiratory route that it is transmitted. Okay, so that is one thing you have to remember. And the last is, seventh disease is tularemia. Tularemia. Okay, so how will you remember it? If you will remember it like this, two together and then tularemia. Anthrax botulinum, AB. Then two old diseases, smallpox, plague. Then Ebola, Marburg. And then there is tularemia who is disturbing the flow. तो ये tularemia ही भड़वा है ना, he is disturbing the flow, he is coming in between. Rest are in sequence. So remember these 7, these are category A, extremely infectious. Then category B are highly infectious, which is very rarely asked. So do try to remember directly category C now. Category C are simple to remember, Nipah and Hanta. Hanta is transmitted by rat, and in Nipah, once they have given this image based question, they draw one tree and some fruit bat flying around it. So that was Nipah, because Nipah is transmitted by date, palm sap or pig. Okay. So category C only 2, Nipah, Hanta. Category A 7, which you remember. Category B is brucellosis. Then there is psittacosis, ricin toxin, staphylococcal toxin. But they are very rarely being asked, so you need not remember B. But if you want, you can. Okay. Now, patient is on OCP, which cancer should not be seen? OCP decreases to cancer and increases to cancer. That's how we used to read in the past. And it's very simple to remember. O for OCP, O for outside cancer. Again, this is one thing we have discussed it in our last session before exam. OCP, O for OCP, increases outside cancer. What are outside cancer? In a female body, breast and cervix are outside. Of course, I know cervix is not outside, vagina is outside, but still breast and cervix cancer, these are increased by OCP because they are outside cancer. And OCP decreases inside cancer. What are the inside cancer? Comparatively, ovarian and uterine. Now, uterine cancer can also be called as endometrial cancer. Now, there is a recent controversy. A lot of books, they say that breast cancer is not increased by OCP. Only cervical cancer is increased. Even PAAR has written that only cervical cancer increases by OCP, not breast cancer. So, at least we can remember it like this, that cervical cancer by OCP. How can you remember it? OCP. So, OCP increases cervical pain or cervical cancer. OCP increases cervical cancer, OCP. And it decreases inside cancer. So, endometrial is definitely correct, which is decreased, not seen or decreased by OCP. Okay. Now, what if the CD4 count is less than 100, then which disease infection can occur if it is less than 100? This was a really tough question, I think. And to help you here, this image of PAAR will help. If you will see, it's a very clear image which is saying that if CD4 count is less than 50, in less than 50 category, there is disseminated Mycobacterium avium complex, histoplasmosis, cytomegalovirus retinitis, and CNS lymphoma. These 4 occur if CD4 count is less than 50. If it is between 50 to 200, pneumocystosis, toxoplasmosis, cryptococcosis, coccidomycosis, and cryptococcosis. So, simple way to remember is less than 50 is very less. It's almost history. Patient will be dying now. So, history means histoplasmosis. Histoplasmosis is here. MAC. That means the patient will be almost dying. So MAC is Mycobacterium avium complex. MAC and history will be less than 50. Other than history, all sources are here between 200 to 50. All OCs are there. All OCs are here except histoplasmosis, which is less than 50. Like pneumosis, you understand the point. All OCs are between 50 to 200. And more than 200 are the remaining candida, herpes and all those things. So except histo, which is history, which is less than 50, rest all are between 50 to 200. Okay. So now let's come here. Less than 100. Candida, we see 200 to 500, and above it. Staph aureus not there. Pneumocystis jirovecii and MAC. So pneumocystis is written here. Pneumocystis is here na, between 50 to 200. But MAC is definitely less than 50. So if they ask less than 100, better answer will be MAC. Because pneumocystis jirovecii, you can see there, was between 50 to 200 CD4 count. So this image, this classification will help you to remember and do this question correct from the next time. Remember the mnemonic, myremi and histoplasmosis are less than 50, MAC and histo are less than 50, rest all OCs are between 50 to 200. Okay, so that is there. Now according to step approach, what is not included? We have discussed this in our image based session just before the exam. ABKI BAAR 200 PAAR had this discussion, that is step approach. What are the three things? So in the step, first thing they ask is the question related to their behavior. And actually what is step approach? If you want to know that in China there is more high risk patient for diabetes or in India, how will you know it? To know it, you will take 5,000 population randomly from India and 5,000 randomly from China. And then in all of those 5,000 people, first you will ask about their behavioral problem which is causing them to be at high risk for NCD. Then you will ask about the psychological problem. And of course, behavioral and psychological are almost the same thing. So step approach help us to know and compare high risk population for NCD. It helps us to know who are at the high risk for NCD. And this was a repeat question from NEET exam. Actually in NEET they have asked already about a step approach, but in a different way. So if you will do NEET 5-year, a lot of AFMG question will be done correctly. MCI exam will be done correctly. And the vice versa is also correct. So please do not ignore importance of NEET. And best thing is, early in your preparation, one time do PYQ question. Don't wait for your theory to be finished and then I will go on PYQ. No. Because if you will wait for your theory will be finished in October, November, then you will not be able to revise PYQ. And then like many other people who said PYQ did not come, you will be saying the same. PYQ always come, 30-40% is always PYQ. But because we are not revising it, so we are unable to remember it. I will suggest you not to do question from apps and all, because if you will do question from app, you will not be able to revise it. But if you are doing PYQ one time in this first 2 months, then you will be able to revise it 2-3 times before exam. And then the PYQ will be under your grip. And remember, 90% question always come from same topic as PYQ. Same topic as PYQ. That's why I am emphasizing you to get a command over the topic. Okay, the topic should be in your grip. So try to do PYQ in the early 2 months so that you can revise it 2 times before exam. Now, in the step, first is behavior and psychological problem. So which behavior make me high risk for NCD? One is my smoking behavior, second is my drinking behavior, third is my eating behavior, fourth is my not exercising behavior. So smoking, alcohol, then the diet, exercise, these all come under behavioral thing first. After behavioral, we ask for physical factor. And in physical factor, we take BP, we take body mass index, and we ask age. And then we have the last factor, which is hormonal or biological. So in hormonal or biological factor, in India we take random blood sugar only. But in Western country we can take lipid profile and thyroid profile, but not in India. So in NEET they have asked which criteria do not come under step surveillance. Behavioral criteria, psychological criteria, physical criteria, or therapeutic criteria. So therapeutic criteria do not come under it, because the purpose of a step surveillance is not to treat. The purpose is to screen and then to know in which country more high risk population are there. Okay, so therapeutic factor do not come under it. And you can see blood lipid do not come under it in India. In Western country it can be there, but not in India. Blood sugar we measure, but we measure which blood sugar? Not fasting. Random blood sugar is measured at sub-center only. Blood group, oh, but the better answer will be better than blood lipid, blood group, because blood group is not at all related to non-communicable disease. So we do not do blood group testing whether it's in India or in developed country. Okay, but blood lipid is something which is done in developed country. So blood lipid can be included, but blood group is not related with anxiety, so not included. BP and blood sugar we do take. So this is the step approach. I hope you will remember all the criteria, all the things that we measure. Along with RBC, there is blood lipid profile and thyroid profile. These two we do only UK and all Scandinavian countries and all those developed countries. Okay, to remember. Chalo, delayed wound healing after minor surgery. Delayed wound healing is vitamin C. But if they ask, and it is written here, you can see, the function of vitamin C is it's an important antioxidant, and it is needed for formation of collagen. That's why they have asked previously that collagen synthesis defect. It occurred due to which vitamin? Vitamin C. And this collagen synthesis defect lead to delayed wound healing. Okay. So it is vitamin C, that's clearly written. And local hemorrhage can occur, bone fracture can occur easily, and then vitamin C also help in absorption of iron. That's why we give, कहते हैं ना नींबू पानी लो iron की गोली के साथ है ना, take lemon water with iron tablet, because it help in absorption of iron better. So these are all written, and do remember what is the richest source of vitamin C? Indian gooseberry, amla. This is the richest source of vitamin C. Okay. Now, in next question, some people say that they have asked patient with gum bleeding and poor iron absorption, they have asked. So if they ask poor gum bleeding and poor iron absorption, again it is vitamin C. Same thing, gum bleeding, poor iron absorption. Then some said that the patient question was that it is micronutrient deficiency with poor wound healing, diarrhea, dermatitis and alopecia. So if it is still poor wound healing, it can be vitamin C. If they add these three criteria, then it will become zinc deficiency. Diarrhea, dermatitis, alopecia is zinc. We have discussed it in the 100 question session just before exam also, and in NEET also it came that a patient come with dryness around mouth and nose. What he is suffering from? He is suffering from zinc deficiency. This is the feature of acrodermatitis enteropathica. And this acrodermatitis enteropathica occur with zinc deficiency, and due to this zinc deficiency nothing will be absorbed. सब छर बह जाएगा, सब छरछरी हो जाएगी. Okay, so that's why zinc is very important to absorb all other nutrient also. Now you can see it here also. I have put thiamine, zinc and vitamin C together, so that you should revise these three again and again. Now in this zinc part, you can see it is written that zinc can also lead to growth failure and sexual infantilism in adolescent. Okay, choti goti, है ना, sexual infantilism can occur. Then zinc deficiency is common in children due to lack of intake of animal food, and increased fecal loss during diarrhea can cause zinc deficiency. So that's why zinc is supplemented in ORS, and the zinc supplementation in ORS is 10 milligram or half tablet till 1 year, and 20 milligram or full tablet if the child is more than 1 year. And zinc supplementation is given for 14 days. Zinc help in reformation of cilia wall and help in absorption of other nutrient also. And one more question came that in ORS, glucose and salt, do they do co-transport or do they do exchange transport? So ORS, the salt and sugar, they do co-transport, they co-transport together, okay, like that. Chalo. So this is all being written here. If you read it detail, you will know that zinc deficiency can also lead to spontaneous abortion. It can lead to congenital malformation and anencephaly. They can ask this part next time, okay. So do remember it. Now next and last question, and then there is 2 more questions left. In this, what is the defect? Of course, this is talking about filariasis. In filariasis, microfilaria larva resides means live and grow in lymphatics. So because it live and grow in lymphatics, so there is lymphatic blockage, and the name of the larva is microfilaria, and because it only grow in lymphatic, do not multiply, so the life cycle is cyclodevelopmental life cycle. Because cyclodevelopmental life cycle do not multiply, it only grow. In INICT they have asked, it is example of which level of prevention if you are taking care of this type of filariasis foot. So if we are taking filariasis foot care or diabetic foot care, these all are example of disability limitation. And disability limitation is an example of tertiary level of prevention. So it is tertiary level prevention, disability limitation, do remember, okay. Now, and of course the blockage is in lymphatics. Yes, Dr. Ritik is correct. Now, a child presenting to clinic with history of cough, coryza, conjunctivitis and fever, on examining rash is seen behind the ear and then go to face. Behind the ear and then go to face, or behind the hairline, and then to face. This is characteristic of measles. So definitely it is measles. Second thing is, in rubella chickenpox, we have discussed it again and again, that there is dry fever with rash. So in both of them, no cough, cold, coryza will occur, that occur in measles. Plus, how will you differentiate measles with chickenpox? Measles rashes are in the skin surface, they do not come out, but chickenpox come out. That's why it is chickenpox. And chicken ki chonch ki tarah nikal aata hai. It come out like a chicken beak. So chickenpox is out from skin, measles is in the skin. That's like measles rashes are sand particle rashes, they call. And of course measles will have coplic spot also. The coplic spot will be near upper molar or lower molar. It will be near first and second lower molar. Upper molar will have extension duct from parotid gland which is opening. Now extension duct will not travel all this distance and come to lower molar. So extension duct open upper molar, coplic spot lower molar. Measles in the skin surface, chickenpox coming out. Which will, chickenpox is centripetal or centrifugal? Very simple. Chickenpox CP, CP means centripetal. It is in the trunk and back, it is not on hand or sole. So it is centripetal. Okay, do remember. And of course pleomorphic, different stage present together. The isolation which we do in chickenpox is for 6 days, and then we give varicella zoster immunoglobulin in 72 hours. Varicella zoster immunoglobulin is preferred first in pregnant female, and it is not needed in adult. Pregnancy we give it and not needed in adult. This was the question in NEET exam recently, so I am repeating it here. Not needed in adult. In adult boys hostel, a chickenpox outbreak happened. Which step is correct, they have asked. So first step, isolate the patient for 6 days. Second, give varicella zoster immunoglobulin. No, because this is a boy hostel, adult boy hostel. So not needed varicella zoster immunoglobulin, not given in adult. Okay, we give it 72 hours, but not in adult. What is incorrect about measles? The symptom of measles incubation period is 10 to 14 days. So this is correct. Period of communicability. Period of communicability means the duration till which the person can infect other. In case of measles, the period of communicability is 4 days before rash to 4 to 5 days after rash appear. Okay, so this is the period of communicability, 4 days before rash to 4 to 5 days after rash. And period of communicability is the duration of isolation. We isolate someone till the person can infect other. And incubation period is the duration of quarantine. Remember, quarantine is done on the people who are looking healthy but are suspected of carrying infection inside. Okay, so they are kept in a separate room till the maximum duration of appearance of symptom pass away. Okay, so quarantine is done till incubation period, isolation is done till period of communicability. Both are example of primary level of prevention. Okay, and do remember these two questions which they ask. So incorrect is about period of communicability. Incubation period is 10 to 14 days. Option A is correct. Okay. Last question, a patient presenting with, no, second last question. Presenting with loss of cold sensation followed by hot touch and pain, what the patient is suffering from? He is definitely suffering from leprosy. In the PAAR it is written that in leprosy, hypopigmented patch will be there, but the earliest sensation which will be affected will be light touch. So if in any patient touch is affecting first, that is definitely a case of leprosy. Okay, so do remember. Other thing, there will be thickened nerve, and most common thickened nerve which we can easily palpate is ulnar nerve. I hope you all know. Or we can also do biopsy, Jaden smear on biopsy. Okay. So either we can do biopsy or any one of the first three symptoms present, then diagnosis of leprosy will be confirmed. Any one of the first three symptoms or Jaden smear showing positive report. Okay. So next question was that a 3-year baby presented with complaint of diarrhea. On examination, baby is severely dehydrated, lethargic, and have a high respiratory rate, and BP is 80/60. So what fluid we will give? So the patient is lethargic and severely dehydrated. In severe dehydration, we give IV fluid. So giving ORS is not an option here because he is severely dehydrated and lethargic. So we will give IV fluid. IV fusion we can give with normal saline. IV infusion we can give with ringer lactate also. But in this type of cases, we always prefer ringer lactate, which has more amount of potassium, which resemble our intracellular fluid more. So we can go with RL. This dextrose we never give. We can give normal saline also, but usually in such cases and in burn patient also, we go prefer with RL. Okay. Now next question was that mother is a known case of HIV but not taking any ART. What newborn prophylaxis should be given? So we do give nevirapine for 6 weeks because nevirapine is hepatotoxic. So after 6 weeks, we do not give nevirapine, we replace it with other drug. So if you ask the ideal answer is first we give nevirapine up to 6 weeks, and after nevirapine we will replace this thing with zidovudin plus lamivudin. These two things will be given till 1 year, and if the zidovudin and lamivudin is unable to control it, then we can add raltegravir, but mostly zidovudin, lamivudin usually able to control it. So this is the ideal answer. 6 weeks to 1 year we give these two drugs. But this was not in the option. So then let's go back to the guideline and see what PAARC is writing. PAARC is writing that provision, if you see here of point number 7, provision of counseling and support for initiation of exclusive breastfeeding within an hour, and exclusive breastfeeding is given till 6 months. You have to focus on point number 8. 8 number point is saying that antiretroviral prophylaxis of infant from birth up to a minimum of 6 months. So till 6 months we always give prophylaxis for HIV, and in that 6 month first drug we give is nevirapine, because nevirapine is given 2 mg per kg per day, oral once a day dose, easy to give. So nevirapine is definitely given. Along with nevirapine, if being asked what is the second drug which you will give, then answer will be zidopidine. And remember, nevirapine is hepatotoxic, so we do not continue it usually after 6 weeks. So nevirapine till 6 weeks, and then zidovudin plus lamivudin till 6 months should be the ideal answer. And do remember, they have asked this question also, will you do ELISA? No, we don't do ELISA here. We do HIV DNA PCR at 6 weeks. At 6 weeks, we do HIV DNA PCR testing for detecting it. And P24 antigen give report more earlier than ELISA, but here we don't do P24 antigen, we do HIV DNA PCR testing. Okay. Now, at 6 weeks. So what is the correct answer? Nevirapine till 6 months we cannot give alone because it is hepatotoxic. 6 week guideline has removed, said that minimum prophylaxis should be 6 months. So minimum should be 6 months, and only option where along with nevirapine any other drug is given is D. So better out of the 4 is nevirapine and zidovudin till 6 months. But this will be the ideal answer. And if you have to give till 6 months only, then again first give nevirapine, then zidovudin plus lamivudin till 6 weeks to 6 months. Okay, but if being asked, D can be given. Okay. So do remember, due to this guideline thing, point number 8, we are not answering nevirapine 6 weeks because they say minimum it should be given up to 6 months. And so minimum should be up to 6 months. That is the reason we are going for 6 months. Chalo, so last protein requirement for 55 kg female. Whenever I teach it in a class also, I say that I hope you all know the weight of a reference male is 65 kg, weight of a reference female is 55 kg. And why are we reading about reference male and female? Because you all must have seen Akshay Kumar in that ad of Horlicks. He comes jumping from the table and say that whatever is your weight, you should eat 1 gram protein per kg body weight. And I almost broke my speaker. So that Akshay Kumar ad is wrong in 3 ways. First thing wrong is, he is saying 1 gram, but we don't need 1 gram per kg. We need 0.83 gram per kg. Because my weight right now is 95 kg. And we don't give advice like this, that whatever is your weight, eat 1 gram. No, if I took Akshay Kumar advice seriously, and I started eating 1 gram of protein per day, then there will be more parts hanging from my body. You know? So we should not give advice like this, that whatever your weight, eat 1 gram. We have to give advice based on reference male and reference female weight. So if you multiply 65 with 0.83, it will come around 56 gram. And if you multiply 55 with 0.83, it will come around 45 gram, 44 point something or 45 gram. So all the student, boy or girl listening to this video, please remember, I hope you all remember this point, that the ideal weight is 65 and 55 for male and female. If you reduce 10 from it, that will be the dose of protein. So for male, 65 minus 10, 55. For female, 55 minus 10, 45. So that is the answer. 55 kg female, 45 should be taken. Just reduce 10 from the reference male and female. Okay, if it is not 55 kg, suppose it is 95 kg, still the answer will be same. For a 95 kg female also, the dose is 45. Okay, for a 105 kg female also, the dose is same 45, like that. Okay, so do remember it. And as we discussed earlier, school health program come under Ayushman Bharat. It is written in PAAR also. School health program is under Ayushman Bharat. And when they have included under Ayushman Bharat, they are doing 2-3 new things here. First thing is that every Tuesday will be celebrated as Health and Wellness Day. And they are selecting one male and one female teacher. Why? Are they planning to do couple dance? No. They are also selecting one boy and one girl from each class. Why? Because the purpose is, this male and female teacher will be made as health and wellness ambassador. They will be the ambassador, Gadi, an ambassador. And boy and girl will be health and wellness messenger. And what is the purpose of selecting ambassador, messenger and all? To train student in yoga and meditation. Kyunki yoga se hoga. So this is the purpose of Health and Wellness Day. Health and Wellness messenger and ambassador, they will motivate a student for yoga. Kyunki yoga se hoga. So this is one thing which is included in school health program. Okay. Now, one last question was, what are the component of Ottawa Charter? Which of the following is a component, which of the following is not a component, like that they can ask. So Ottawa Charter has this logo, do remember the logo. And we can remember the 5 things being written in PAAR very clearly, so that's why they ask it. But this is something which even I don't used to teach. I should have taught, but this was a new also. So you can see 4-5 question was directly new, 4-5 were really twisted. So I can say that this time the exam asked you a very upper level of question. It looks simple, but they were twisted. So focus here. What are the 5 things? First, build healthy public policy. After building policy, what will you do? You will create supportive environment for health. After creating supportive environment, you will go to the people and you will strengthen community action for health. When the community is done, then you will go personal level and develop personal skill. And when everything is done, people are activated, person is activated, community is activated, then we will reorient health services. Reorient health services means we should not focus on treatment, we should then focus on prevention. And like yoga, meditation, all those things. So, how will you remember the 5 steps? Because it can be confusing. First is make better health policy or public policy. So, first is policy. After policy, you will try to create supportive environment. So, after policy, you need to have supportive environment. And police needs supportive environment, otherwise how police will work? So, policy, supportive environment. With that environment, you will first go to community. So, there is community awareness, community action as the third point. And after community, you will focus on person. So, then there is personal skill. And after person is activated, then they will focus on prevention, focus on reorientation of health services. So, after personal skill, reorientation of health services will be done. So, can we remember it right now? I hope we all can remember it right now. First is policy, second is supportive environment, third is community action, fourth is personal awareness, and fifth is reorientation of health system towards prevention. These are the 5 components of Ottawa Charter, and these were the question asked in MCI exam of July 2023. Best of luck, my dear friend, for your future endeavor. Do revise PYQs of last 5 years 2-3 times before exam, and do not just focus on question, also focus on their topic and get a grip over the topics which has been asked earlier. That is the way to clear the exam in this 5-month preparation time. All these slides which I have shared, I will share it on this Allen what is this, Allen Telegram or WhatsApp group is there. We will share it there also. Plus, you can ask it from me personally also. This is my WhatsApp number. You can, I will share this thing to you personally also if you want. And you can also join my Instagram channel. I have created it recently only. That is by the same name, Ashwani Ranjan, no PSM or anything, Ashwani.Ranjan only. And that is on Instagram also. You can ask for these things. And if you have any doubt, any question, feel free to communicate with me on my number. Keep enjoying your life, whatever the situation is, because happiness is our choice. It does not depend on external situation. Okay? Thank you so much. Hasta la vista. Das ka dhaniya. Bye bye. Thank you, my dear friends.